So I think we can slowly start. So before passing the floor to moderators, speakers of today's sessions, I would welcome all of you on behalf of the ERN-EuroBloodNet and the ASCAT members and steering committee to these sessions. As some of you may know, this project was born 4 years ago, and this is the third edition. So the idea was really to, let's say, bring patients community to the ASCAT conference. And so we start thinking about having educational session. The first year was about research and how to involve patients in research. The second years, we touched different topics, included COVID-19. And last year, we chosen with the patients community and people living with sickle cell disease, the topic to be addressed this year. So yesterday we talked about racism, mental health, and today we are going to talk about pregnancy, and tomorrow we are going to talk about bone marrow transplant. So I'm very happy to open and welcome all of you. And now I can pass the floor to Celeste Bento and Cassandra Trimnell. And thanks very much to all of you for being here.
Hello, good afternoon. Welcome to the third educational session on patients with SCD, organized by EuroBloodNet&ASCAT 2022. The theme of this session is Spotlight on Pregnancy, and we are going to have the testimony of SCD mother, Edda Hummer, and two talks from expert clinicians, Dr. Lau Joseph, hematologist at Necker Hospital in Paris, and Professor Eugene Oteng-Me, an expert obstetrician from London. And we are going also to have a lot of testimonies and questions from the audience. My name is Celeste Bento. I am a clinical laboratory geneticist working at University Hospital in Coimbra, Portugal. I have been doing molecular diagnosis and research on benign hematology, including SCD, of course, for almost 30 years. I am also a member of the Portuguese Association for Hemoglobinopathies, a Associação Portuguesa de Pais e Doentes com Hemoglobinopatias. With me, moderating this panel, is Cassandra Trimnell. She's a patient, a mother, and an advocate for patients. Cassandra, can you please introduce yourself and after this, introduce the first speaker, Edda Hummer?
Oh, my name is Cassandra Trimnell. I am an adult living with sickle cell. I live with sickle cell type SS. I am 34 years old. I am an advocate. I'm the executive director and founder at Sickle Cell 101, which is a nonprofit organization that's specialized in sickle cell education, patient-friendly sickle cell education. As you can imagine, I learn a lot from the work that I do, and it's great to hear about the community. Last but not least, I am a mother. I have a 7-year-old daughter. If she comes in my background, she please forgive me. She doesn't know it better, but I hope to also share a little bit more about my experience in pregnancy as well. So thank you so much for having me. We will turn it over to our very first speaker.
Yes. Tell us your experience as a mother, as a patient, and I think also as an advocate for patients.
Yes, thank you. Hello, everyone. Thank you for having me. And I will share my screen just a second. So again, thank you for having me. My name is Edda Hummer, and I am from the Netherlands. I am a sickle cell patient, also type SS. And as you can see, I have a patient organization here in the Netherlands for patients named Voices of Sickle Cell. I also represent the Netherlands at the European Sickle Cell Federation. And I'm going to take you all with me through my pregnancy story. And I hope you can also learn some things that I experienced. So, first of all, My condition for having children was that my ex-partner would get himself fully tested if he had sickle cell anemia or something similar. This to prevent more sickle cell patients. I wouldn't wish sickle cell upon my worst enemy. So you can imagine, let alone my children. I considered it a well-considered decision to get your partner tested, if only to prevent other children having to suffer from this disease. So if you have a light form of the disease, it doesn't mean that your child has also got the light form of the disease. So my first trimester, my story began, of course, at a hospital bed in the ER. So I was having a lot of trouble with my knees and was yet again at the ER that night. After testing my blood, the doctor suddenly asked me if I wanted to know if I was pregnant or not. So my wish to be a normal woman remained. So my answer was no. As any regular woman, I simply wanted to pee on that stick to get to know if I was pregnant or not. I didn't want to lose that precious moment to a sickle cell patient's hospital life. I'm going to take you with my journey from sickle cell. I have divided it in 3 trimesters. My first trimester was week 1 to 50. My first trimester was a heavy one. As a sickle cell patient, I already had a lot of pain in my back because of the collapsed vertebra. The pregnancy did add only more pain to my back. Also, as a sickle cell patient, I was usually very tired. Now I wasn't allowed to do the blood exchanges anymore because of the pregnancy. So I was exhausted. So if you're pregnant, you are not allowed to get blood exchanges, like I said, but you are allowed to get transfusions. So there is a difference in exchanges and transfusions. So maybe the doctors can explain that later. The second trimester was from week 16 till 27. Doctors usually call the second trimester the best trimester of the pregnancy. It was my best trimester until I met week 27. Before week 27, I had a lot of pain in my calves. At the end of the day, I couldn't even stand on my feet and wasn't able to touch my calves because of the pain. So week 27 was a week to never forget. I once again was hospitalized because of my pain and of my hard belly. Now you have to know that the city I live in doesn't have an academic hospital. The only hospital that is specialized in sickle cell is the one in Amsterdam, a 1-hour drive from my city. I was nearly having a crisis, so the hospital decided, for the safety of the both of us, to get me to Amsterdam. I was carried away by ambulance, and at the ambulance my crisis started. Now you have to know that I wanted to have a normal pregnancy. I wanted to have a normal beginning for my kid, just like other kids. Because of that, I didn't even take an aspirin till that week. At the hospital, they took me to the recovery room to monitor me, whilst giving me morphine. I was crying both in pain as the morphine ran through my veins. Despite the crisis, they prepared me mentally that there was an option to have an emergency C-section. Although for me, it felt like they were going to butcher me and take my kid out of me. I finally pretended not to have pain anymore, just to stop them from giving me more and more morphine. I wanted to protect my kid from morphine. A discussion started between me and the doctor. From his point of view, I could receive morphine. According to him, it wasn't more harmful for the kid than the stress I experienced from the pain. But for me, it was, something else. So I finally made it to the third trimester. After week 27, I was looking at how much longer my body was able to carry the kid. Every day I became more and more difficult for my fragile body to carry the kid. Even though I've been able to carry him till week 36, we decided along with the doctor that at that point, it was time to deliver the kid. I now had to decide in which hospital I wanted to deliver. Like you can see, I have shown you where I live at Deventer, at the Red Dot, and Amsterdam is a 1-hour drive. Deventer made great preparation and had a protocol that they discussed with me. From my experience, I can say it was a really good feeling to discuss the protocol together. I want to advise all the patients and the doctors here to go over protocol together that you both feel comfortable with. Then you are both better prepared for what can be expected. Amsterdam didn't discuss a protocol with me. This is why I chose Deventer to do the delivery. The delivery, a sickle cell patient can't wait for the contractions. Any sickle cell patient has a planned delivery to prevent crises. On Monday, we started my contractions with an IV and they put a balloon inside of me. These contractions were awful. Looking at the experience of other women, it seems that IV contractions are the worst. After 2 days and 2 nights of contractions, I finally gave birth on Wednesday to my beautiful boy. And that was on January 31st, sorry. So this Monday is his birthday. And this is my experience with a pregnancy. Thank you all.
Thank you so much, Ada, for sharing your experience. I really appreciate it. It's very eye-opening. There was a question that came up within the chat that everybody was wondering, and I'm hoping a physician can speak a little bit more to why you couldn't have exchanges. I'm not sure if it was specific to you or if that was a general all-around rule in the Netherlands. Why weren't you able to have exchanges? And please, any expert, feel free to chime in as well.
I'm not sure, but exchanges is that they take your own blood too. You are, it's like two, what's the name? You have two veins. One at the one they took your blood out, and at the one the donor blood is going in. But I don't know why exactly you're not allowed to give your blood out. But yeah, I guess some special person has to take that answer.
I think Eugene has his hand raised. We would love to hear from Eugene.
Yeah. Equally, Ida, I'm not sure why they stopped the exchange. Clearly, for us patients who are already on exchange, we continue the exchange in pregnancy. Secondly, there is one important publication almost 22 years ago by Koshi et al., where mothers were randomized or put into a study of exchange versus standard care and transfusion if needed, almost 36 in each arm. And it showed that the frequency of crisis reduced significantly. They didn't show a difference in terms of the outcome of the babies because they weren't powered enough to show that. But certainly mothers are now coming into pregnancy already on exchange, and we feel that actually it may help. And in my talk, I will allude to the next steps of that study. But I think if you are on it already, certainly we would have continued with it.
Thank you for that response. It looks like we can take one more question. I have David. Do you want to go ahead and unmute yourself and ask the question before we continue on?
Good afternoon. Not a question, but the response to the exchange, why not taking during pregnancy? And then a question. From my understanding as a doctor, pregnancy is a cause of anemia. sickle cell disorder is also a cause of anemia. There's a risk of anemia in pregnancy. And within the first trimester, the risk is high for anemia to occur in pregnancy. Secondly, within the first trimester, that is when the growth of the baby, organ development and everything starts. So within that first trimester, it's more of a risky period. Maybe that is the rationale behind why exchange is stopped during the first trimester. So that's just my understanding as a doctor. Maybe if you have an obstetrician and gynecologist, they can explain better. Now, a question, Edda, thank you for your, I hope I pronounced it right. Thank you for your presentation. You did mention that first trimester from the first week to 17, is it 17 weeks?
15.
15 weeks. I want to know why, because from my understanding, each trimester is 13 weeks. That's what makes it 39, 13 weeks first trimester, first to 13 week, then 14 to 26 weeks second trimester, 27 weeks to 38 or 39 weeks. But if you're categorizing it as 15 first trimester as first week to 15 week, I don't understand. Maybe it's a new teaching, I don't understand. But what I know from medical school is each trimester is 13 weeks.
Yeah, I just categorized it myself. It's not that I used some rules that I read on the internet or what you learned on school. So I just did it by myself.
Oh, okay, no problem. Thank you.
No problem.
Wonderful.
I think there are no more questions. Everybody wants to ask something. Okay, I'd like to ask one thing, Hida. And during your childhood and your adolescence, how did you deal with your disease and the opportunity to be a mother in the future? What did the doctors told to you about this?
Actually, the doctors told me that a pregnancy was really hard for me. So at a really young age, they prepared me that I maybe could not be able to be a mother. And yeah, so I'm so thankful I am a mother right now. Really, I am. But yeah, it was really hard also to check my partner if he has something, because I really didn't want my kid to have sickle cell or something similar. So yeah, that's also a really hard discussion that's on the table, because you don't want, if your partner has something, and I was really hard in that point, so I didn't even want a kid if he had something. So yeah, I don't know if I answered the question really.
Yes, perfectly. Yes. I think this is a point, and that's why this session is so important. That people have to know that with sickle cell disease is possible to be pregnant and to be a mother, because also here in Portugal, the GPs and the gynecologists told the adolescents, okay, forget about be a mother or have a child, because it's not possible in your condition. And I think it's one of our responsibilities, prepare these young ladies that, of course, they can be mothers if they have a very good doctor with them.
Dr. Bento, thank you so much for bringing that up. I just wanted to add that that's a common thing within sickle cell that I hear from a lot of women. They're told from at a very young age that they're not able to have children. I grew up thinking I was not going to be able to have a child, and that it was very risky. I've had the doctor say, just flat out tell me I should not have a child. It will make, things worse. And I understand it from situation to situation. And it is a situation was completely different from mine. And I can perhaps talk a little bit more about my experience being pregnant, but I think that narrative or that message sending out to women that we are not able to be mothers is very damaging. And I just want to make sure, with proper precautions and making sure to take your health into consideration. Of course, we can't have a blanketed statement and say everyone can have a child or nobody can have a child, but it is possible within sickle cell.
Yeah,
Yes.
I mean, I will support that, and I think a compliment to all of you and for putting this educational program on. Clearly, our focus should therefore be on improving awareness and education, and that is why your organizations, and in the UK, the Sickle Cell Society, and actually politicizing what we need to do in sickle cell, particularly throughout the life course, becomes so important.
I also see a question from someone asking what advice I would give to other people with sickle cell looking to become pregnant. Can I answer that question already, or is it for the end? Yeah.
Yes.
Okay. Okay. Because I want to advise actually to find yourself a doctor that would match with you, a good match, and that will think through with you. Like I said before, I had a really good protocol in Deventer. That's why I chose Deventer and not an academic hospital that actually has to have a protocol and that has to discuss it with me. But a small hospital, it discussed with me a protocol, and I was really glad that they discussed it with me. And I was going in my delivery like I knew everything. I knew what if there came a crisis, what they would do, and who would come. And you have to find yourself a really good doctor, actually.
Yes.
No.
Yes. Like for other women, a good doctor is always the best condition. But I think also communication is good. Communication and have the opportunity to talk with other women. Did you talk with other women in Netherlands that have been already pregnant before you got pregnant or during your pregnancy?
There was a really hard one because here in the Netherlands, the patients I know, they don't have already a kid or they weren't pregnant. So I actually was, from the group people I knew, I was the first one that I had a child. So yeah, those, and I didn't had already my organization that came after that. So I know more people, but before, yeah, I didn't know that much people.
Yes, and I think that's why it's important, this kind of international organizations,
Exactly.
because we can talk with different people from different countries, and I think communication and sharing information is very, very important.
Yeah.
Okay. If there are no more questions, so I think we can move on. I would like to know if there are questions from the audience or any comment from the doctors in the audience, the clinicians.
I see someone.
Professor John James, you have your hand raised.
Thank you very much, and thank you, Laura, for that helpful presentation. The question I had is how you defined mild sickle cell patients, because that feels to me very difficult unless you have split it by phenotype, because some people say if you have sickle cell, it's you might be free from a crisis for 18 months, a year, but when you do get the crisis, it's awful. So I was trying to understand how you defined mild sickle cell disease. Thank you.
Thank you for your question. So it was really difficult to, we need to separate populations in this study, because I think there is different kind of severity during pregnancy and different population, but we have no idea of genotype, because in France the code don't precise this. It's just sickle cell anemia, and
Okay.
it's all. So we choose, I know it's not perfect, to because I think most of patients in France, severe patients, were treated by hydroxyurea when they experience many vaso-occlusive events or acute chest syndrome or organ damages. So we choose to include in severe disease the treated one, and we included 2 transfusion programs for vasculopathy damages and other organic damages, or for patients with failure of hydroxyurea. I know that don't include patients with intolerance on the failure of hydroxyurea and alloimmunization or impossibility to transfuse. So it's not perfect, but I think it's best we can do.
Thank you. Thank you.
I mean, I think if I could come in here with regards to John's point, we often actually make it poignant that irrespective of the genotype, with regards to pregnancy, it's important to treat all sickle cell mothers the same. We have had, fortunately, there's universal screening in the UK of all mothers in most of the regions which are extremely diverse. And that ensures that occasionally we do have mothers who, for the first time, the diagnosis of sickle cell is made. And in fact, we do have examples of those mothers having eclampsia or preeclampsia later on and developing significant manifestation of sickle cell disease during their pregnancy. So even though they may have been completely well, it becomes very significant in pregnancy. So the dictum is to manage irrespective of mild or severe outside pregnancy, to treat them almost the same.
Yes, I confirm, and I think our study confirmed it, because we found a significant difference between mild SCD and French populations, even it's not treated people. I think we think the same.
I have more a curiosity than a question, Professor Laura. I didn't understand. You don't know the genotype of these patients, or
yes,
but because it's not done, or because you are not allowed to know it? Because
it's not collected in the register. It's only called a sickle cell anemia, but with no precision of genotype.
Okay, but
with no different codes.
Yes, okay. But in fact, the doctors don't know the genotype of these patients.
We did not know, yes. But I think it's done. In this hospital, they knew the genotype of patients, but we have no.
Access to them. Okay, thank you.
Could I follow up with a question and ask, even though genotype isn't known, how is it still measured, whether it's mild? Is it by number of crises per year, the amount of pain? How is that still measured?
No, it's like I'm sorry, my English is far too perfect, so I think it's hard to understand. But I explained that we choose to separate in 2 groups: one with specific treatment for sickle cell disease, hydroxyurea, or a transfusion program in the year preceding pregnancy. This population was defined severe, and the other patients was defined mild. We don't, because as you know, sickle cell disease is never minimal, I think. So we choose to separate only in 2 groups, because I think there is many SC genotype, S beta plus genotypes, who have many complications, and not. And I don't want to call them little sickle cell disease. I don't know. I don't find the good words, but I think it's. I hope I'm more clear.
Absolutely.
I have also a question. because I wasn't allowed in the Netherlands that I was get off my blood exchanges when I was pregnant, and while after I gave birth, I got on the program again of exchanges. So I always thought exchanges was damaging for the baby in my belly, but isn't that true, or what is it? I don't understand it actually now.
I'm to be honestly, I don't understand too, because it's very curious to stop your exchange or transfusion during pregnancy. For patients who have already transfusion program, we continue during the pregnancy. So I don't know why they do that for you. I have no explain, but maybe it is explained by your history. I don't know.
Okay, thank you.
Maybe it's for alloimmunization. Maybe you have some antibodies against red blood cells, and they were afraid by a new reaction. Did you know?
I was actually just on the program of exchanges. I got off transfusions and was just 1 or 2 times, no, maybe more, but not long ago. I was on the exchanges, and then they put me off again. So I don't know. I really don't know.
I mean, Ida, I think sometimes our patients are our best teachers. The fact that they took you off and started it again after delivery means that it's not contraindicated in pregnancy. You should have continued with it in pregnancy. There are numerous examples, and as Laurie alluded to, in France, in the UK, we would have continued. And we do have patients sometimes actually being expert because they live with the condition. And in fact, sometimes regular exchange actually makes you so independent. And we do have our data supporting that. So personally, I think they should have continued with it.
Okay, thank you.
Yes, but in fact, every case is a case. And okay, I think Dora is the first to raise her hand.
Yes,
Dora.
I'm Dr. Dora Bashir, and from France, and I have followed a lot of pregnancy in my past. I am now retired, and we have reduced considerably the transfusion in pregnant women because of alloimmunization and delayed hemolytic reactions. So when patients are on exchange transfusion, they are not prone to have delayed hemolytic reactions. We were aware of this complication only in patients who had received a few transfusions or no transfusion. So it's very important to notice that, because we have had deaths with delayed hemolytic reactions. So it's just to add a commentary to Dr. Laure Joseph. Bonjour, Laure.
Bonjour, Dora.
Thank you. Professor, do you want to say something, Dr. Laure?
Yes,
No.
I wanted to add something. I have prepared the slides, and I didn't know that Laure was speaking, but I am now involved in therapeutic patient education. And so we have integrated this part of care for all patients who are pregnant since 2 months. So it's just new, but we have at the time here in Mondor Hospital, where I work and where I worked before, we have 30 patients who are pregnant with sickle cell disease. And so we have begun to see them during the out-clinic visit, and each month or every 2 months, and is very successful because we see that patients are very anxious, and sometimes they met in the obstetrician department anesthesists or young doctors who say that you are mad to be pregnant. And so we have to reinforce that the pregnancy is possible and successful. And I think where you see pregnant women and then they have child, they exist, and they have a life project, and is very important for the quality of life.
Yes.
Thank you. Thank you very much. So I apologize on behalf of Cassandra who need to leave. Noemi, if you agree, I will address one question that is in the chat for Dr. Joseph, and then I will come to you, and then we will pass the floor for the last presentation. So first, the question in the chat, Dr. Joseph, do you have any recommendation for change of routine pregnancy care for patients with sickle cell in France after your study?
Yeah, I think we must there is many things I think we could change, but the first one is to continue to address SCD people pregnant to center who are aware about specific complication and therapeutics for sickle cell disease pregnancy. For example, it is very important to plan deliveries in SS genotypes in general, and if you wait natural deliveries, you could have some acute chest syndrome on vaso-occlusive events after. In our center, we we program almost totality, just some patients have no planned deliveries, and with these policies we have almost no hospitalizations after deliveries because of vaso-occlusive events. So I think it's a very good improvement, and there is something to discuss with obstetrician, like aspirin prescription to prevent preeclampsia, because 11% in a population of patients of preeclampsia, I think it's very, very significant. So we actually, when the obstetrician or hematologist see the pregnant woman, he do a score to decide if aspirin is necessary during the pregnancy to prevent preeclampsia. But sickle cell disease is not an important point in this score, and I think this study and others could confirm it is very important to add sickle cell disease in this score to change the actual prescription of aspirin. And other recommendation will be around prevention of thromboembolism and pulmonary embolism with prophylactic prescription of anticoagulation. Actually, we just prescribe in some case in patients who have some history of thrombosis or other history like other autoimmune disease like lupus and so on. But we don't prescribe systematic prophylaxis. I don't know if I'm not sure it is useful for all patients, but I think it will be interesting to analyze a future study who compared systematic prophylactic anticoagulation and no systematic diagnostic like it is done today, to know if this prescription must change its future, because this embolism, for example, pulmonary embolism is very severe, and in our patient it could have some dramatic consequence. And I think there is other, I could talk very longer about recommendation, but it's the most important one. But I agree with Hida. It is very important to communicate with patients and with our colleagues, obstetrics and anesthetists, because all is a question of organization. Plan deliveries, plan pain management, very, very important thing, and plan transfusion management. And that's 3 key points we have to discuss together to be better with time.
Thank you. Thank you. I think Noemi, do you want to say something?
Yeah, thank you. I just wanted to pick up on a couple of points from Ada's presentation. So obviously, Ada, we can't say about your particular case about why you were told that you shouldn't have exchange transfusions, but it really struck by the fact you said you were more comfortable in a smaller hospital, that you had confidence in the doctors, and that had a good gave you a good care plan. And I think that's really important. And I think the other thing to pick up is that you can question your doctors. I know that that's not always something that's easy to do. I know that it sometimes depends on the country where you are, where in some countries that's seen as I think it's harder to do than in other countries. But if you get told by a doctor that you have to stop this or start that, it's your right to say why and what's the evidence, and to even think about, do I need to speak to somebody else? It could be another doctor, it could be through a patient organization. So I just wanted to remind everybody on the call that you absolutely have the right to question your medical team and to seek other opinions if you're not happy or you don't understand why you're being told what you're being told about your own care. That's all.
Yes, thank you. That's like he said, you should be allowed to discuss the protocol with your doctors and everything. Yes, I agree. And Zachariah, you have your hand raised. You want to comment?
You're muted.
Sorry. Thank you all. I have to say hello first to my friend David. Thank you. And just to share with you the good practice of Bahrain. Bahrain, I think we had a good result of 12 years of zero mortality in the mothers and in the child, or the mortality in both the mothers and in the child, infant, because we have done a very good practice by having high dependency unit or semi-ICU unit for sickle cell patients. Also, we combined 2 clinics, one for gynae and hematologist clinic, to see the patient with sickle cell, and that made the safe pregnancy for patient with sickle cell to feel safe to get the pregnancy, and also that help us to push away the stigma that sickle cell ladies with sickle cell couldn't be a mother. Thank you.
Thank you very much. I would read one comment that is in the chat because it's very linked to our next presentation. That says, I'm sorry, the chat always scroll when you add comments. I've lost the comment. So he said, I want to highlight the need for continuous education of caregivers and patients, and especially the need for co-management of patients between obstetrician and hematologists. So I'm happy that today with us there is Professor Regine Oteng-Nim. Sorry for pronouncing your name wrongly. So I'm seeing there are some hands raised. If you agree, I would go on the last presentation and then pass to the raised hand floor, so we can really have a comprehensive approach to pregnancy and hearing also from an obstetrician. So if you disagree, please unmute and say I disagree, and I will pass the floor. Okay, so please, Professor, the floor is to you. Thank you.
So I'm very grateful to the team for inviting me, and very much thank you to Ida and Cassandra for their talk. I will first of all highlight that actually most of pregnancy, despite perhaps my talk and also Laurie's talk, most of pregnancies in our patients with sickle cell disease do very well. And actually, provided that pregnancy is planned, we envisage that the outcome will be very good. So I suppose asking some of my patients what patients should know when they are planning a family. And most women will have a straightforward pregnancy. And that's very, very important to highlight. And I think that the importance of national guidelines, international guidelines, and making that freely available to families and also to multidisciplinary team becomes very, very pertinent. And that really allows the mother to know what to tell some of their clinicians if they are not used to managing pregnant women with sickle cell disease. And clearly you and your partner should meet ideally a specialist or a counselor to advise with regards to the options available to you. Ida alluded to the fact that, and very, very emotive, that clearly for her, she wouldn't wish anyone, let alone her child, to have the condition. And we think that every mother should have a choice to actually ensure that there are interventions available for her in preventing having an offspring with sickle cell disease. And that choice should be offered to her. And clearly the response in some countries is perhaps not for the couples to go ahead and marry or have a baby. And in fact, there are countries with churches not marrying couples, which I think inherently is wrong, which I think in terms of ethics is actually wrong. But the solution really is offered in pre-implantation genetic diagnosis. And most people on the panel through the Sickle Cell Society in the UK has actually fought tooth and nail to ensure that nationally this is funded by the government to ensure that mothers could have babies if they choose to, knowing that their partner may be a carrier, knowing that they may be at risk of having an offspring with sickle cell disease, to choose to have pre-implantation genetic diagnosis, which will avoid them going ahead to still marry, but avoid them having a baby with sickle cell disease. They should have a specialist team, and by that I mean obstetricians, sickle nurses, hematologists, working together to ensure that mother and baby are monitored closely. And by and large, if we do that, the outcome is good for the mother and baby. We have to be hopeful that there are treatments out there which over the years have made of mothers or women with sickle cell disease before they come into pregnancy. So hydroxycarbamide has been around for a long time. preventative medications such as penicillin becomes very, very important. But still, there are gaps in terms of outcome for mothers with sickle cell disease, for adults with sickle cell disease. And hence, we have to keep the campaign going to improve research, to improve the care, innovative care for patients with sickle cell disease. Clearly, during pregnancy, we do not have the luxury of using hydroxycarbamide, crizanlizumab, some of these newer medications, partly because they may actually have implication for the babies. We recommend that during pregnancy, if mothers are on hydroxycarbamide, they should stop it before pregnancy. But we have to be hopeful that the outcome will be good. And where the outcome may not be so good, we should be prepared to do research to bridge that gap. Clearly, a mother may ask, what are the important considerations? Will I need to change my normal treatment? Clearly, if they are on hydroxycarbamide, we will recommend they stop it if they are planning pregnancy. If they come into pregnancy already on it, we will recommend that they continue the pregnancy, that we stop that medication. What extra treatment might be needed? Clearly, Laurie alluded to preeclampsia being so common. We know that if we give that mother low-dose aspirin, either 75, either 150 milligrams, we prevent the risk of preeclampsia by 50% if it's given before 16 weeks. So it goes without saying we should give mothers with sickle cell disease low-dose aspirin before 16 weeks. What extra care would they need? Clearly, they should be on folic acid. During pregnancy, the risk of pneumonia is high. So if they are already not on penicillin, they should be started on penicillin to reduce the risk of pneumonia. At least every 4 weeks, they should see a specialist, both obstetrician and hematologist with an interest in sickle cell disease, and they should work together jointly, communicating where there are challenges so that they could address that together. Clearly, painkillers becomes important, and we ensure that the mothers have paracetamol, dihydrocodeine, but also they have a linked nurse that they can pick the phone to call if they have any doubts or if they have any questions. Importantly, all the centers should have guidelines on pregnant women with sickle cell disease. And ideally, it should be a national guidelines where there has been input from hematologists, obstetrician, patients, as well as nurses and midwives. First of all, the question is that when should I have a pregnancy? Clearly, this data, very complex, but I will try and break it down. Often in fertility specialist centers, anti-Müllerian hormone is a marker for ovarian reserve, for the number of eggs. And clearly for patients with sickle cell disease, the ovarian reserve, irrespective of age, goes down significantly. So don't leave pregnancy too late. And 15% of our mothers in where I work often have their pregnancies over 40. For patients with sickle cell disease, it's important to advise that they should have pregnancies. Perhaps under that age becomes very, very important because it may become difficult later on. Clearly, pre-pregnancy, they should have all the appropriate vaccinations, pneumococcal vaccination, meningococcal vaccination, hepatitis B vaccination, very, very important. And this day and age, clearly COVID vaccination and flu vaccination. The partner screening becomes very, very pertinent. And in the UK, our patients with sickle cell disease are seen yearly. So the partner screening allow us to advise instead of clearly coming into pregnancy, not knowing their risk of having a baby with sickle cell disease. We can advise if the partner is the carrier, there may be 1 in 4 chance. For a patient with sickle cell disease, actually it's 1 in 2 chance, and offer them pre-implantation genetic diagnosis for free. And I have got patients who have come into pregnancy. In fact, I saw one today, having had a termination for a baby with sickle cell disease, then went on to have pre-implantation genetic diagnosis, 4 embryos frozen, the first baby that she carried, non-sickle, and 2 failed IVF attempts, and now pregnant again with unaffected baby. So clearly the life course could be planned appropriately, where the mother have the choice of choosing not to have a baby with sickle cell disease. Clearly, these are the examples that we have published, alluding to the fact that pre-implantation genetic diagnosis, when I first arrived almost 2008 at our center, the success rate was 18%. Now take-home baby rate is 63%. So it's clearly a viable option for our patients. And clearly countries may be advising not to go ahead with marriage because the partner is the carrier. If this is an option for our patients, then ethically they can go ahead and marry if they plan it. Laurie has alluded to the risk of preeclampsia, the frequency of crisis, anemia, infection, acute chest syndrome, cesarean section. But clearly, if we work together, if we have guidelines, some of these adverse outcomes can be prevented and the outcome will usually be good. And hence the need for guidelines, bringing heads together, communicating together will improve outcome for our patients. By and large, during pregnancy, they should be on folic acid. I've alluded to penicillin, and low-dose aspirin becomes very, very important. Consider thromboprophylaxis. Actually, I will say manage with thromboprophylaxis. For our first-time mothers who only complication is sickle cell disease, we start thromboprophylaxis from 28 weeks in terms of low-dose, low molecular weight heparin, and that improves outcomes significantly. We stop hydroxycarbamide, also crizanlizumab, we stop that. And if they are on other medication that may affect baby's development, we stop that prior to delivery. They will have serial growth scans because the outcome of the baby is very pertinent. And hence from 20 weeks onwards, every 4 weeks, we will scan to ensure the baby is growing very well. And we are center that really believe in research during pregnancy to improve future outcomes. So we are beginning to work on placental magnetic resonance imaging to see whether we can distinguish some of the complications that may develop later on. Clearly, they may come into pregnancy with painful crisis. We ensure that they are well hydrated. We ensure the importance of housing. So we have community nurses who are linked to housing to ensure that if the mother is living in a housing that may be cold, they may have means to try and help them find appropriate council housing. Often the use of pain relief, again, we plan that so that by and large they will be on paracetamol, dihydrocodeine, and in some severe cases, oxycodone, but monitored very, very closely. And we allow the use of non-steroidals up to 28 weeks. And still, if they are in pain, they call our sickle nurse or come to our day unit in pregnancy, open 24/7 and be seen very immediately. And by and large, we advise our doctors to admit these patients in our high dependency unit to make sure that the most senior person sees them, to make sure that within 12 hours, our anesthetist will see them and alleviate the pain. They may be on patient control analgesia. It's important for us to monitor that very closely because sometimes they may have reduced oxygen as a result of that. And we do blood gases and we act on that very, very closely by doing a chest X-ray. VQ scan allow us to diagnose thromboembolism very quickly, including spiral CT. And really in these severe scenarios, we act multidisciplinary to improve outcome for our patients. You may say what happens in labor. clearly they would have seen our anesthetist before to plan in terms of what pain relief to have during labor. Some may have epidural, some may choose not to have epidural. And you should have a baby in a hospital that is able to manage sickle cell disease. Very, very important. And there are centers now in the UK actually marked for sickle cell disease or hemoglobinopathy, and it's important for our patients to know about. And all the other centers are linked into these central sickle cell centers to ensure that we are sharing the patients and we are sharing the learning. Blood that is suitable should be available should we need it immediately. And we monitor the baby very closely in terms of continuous monitoring. They should be able to have a normal delivery, but we often advise the timing of delivery to be between 38, 40 weeks if there are no other complications, to ensure that the placental aging becomes important, more so for our patients with sickle cell disease if they go beyond 40 weeks. Clearly, what happens to the after delivery, we ensure that we minimize the risk of crisis, so keeping well hydrated, ensuring that we've provided the thromboembolic advice, and all of our patients will be on low molecular weight heparin, which minimizes or prevents thromboembolism. We offer testing for the baby, goes without saying, where the mother has sickle cell disease or the partner is a carrier, then we actually do our test in the hospital before they go home. Otherwise, in the United Kingdom, there is universal screening for all newborns with sickle cell, for sickle cell disease by day 5. Contraception, very important. Clearly, progestogen-only pills is recommended, particularly if the mother is breastfeeding, or injectable Depo-Provera, implants, Mirena. So none of the contraceptions are a barrier if they are not breastfeeding. If they are breastfeeding, clearly they shouldn't be on combined oral contraceptive, estrogen, progestogen form of contraception. And if they are not, for some mothers, actually, this may be suitable for them. We will recommend not to write this off, but clearly important to ensure that they have no other risk factors like smoking in terms of ischemic heart disease or thromboembolism. And the copper coil is said to have a slightly increased risk of infection. So again, we recommend Mirena there for most of our patients where they may consider intrauterine system. So what can we do in terms of transfusion? Do we transfuse in pregnancy or not? Either alluded to some centers actually stopping the transfusion. Some centers also may routinely give transfusion, particularly at the end of pregnancy. So we ask ourselves, where is the evidence for this? You may ask ourselves, why are these complications? It may be because of the sickle cell disease, where the S percentage is very high. If we provide exchange transfusion, we will reduce the S percentage, and that may improve outcome. So fundamentally, there may be a rationale mechanistically behind this. So why not provide exchange transfusion? We've alluded to the fact that there may be side effects. It's important for us to do research about this. And what we've asked our funding body is that, do we need to do a definitive research to see whether prophylactic exchange blood transfusion may help? We cannot give the current medications that you can use outside pregnancy, hydroxycarbamide, crystallizumab. We cannot use this in pregnancy because of the concern with the development of the baby. I'm afraid we are left with blood transfusion. We have to find an answer by doing more research. But clearly, will our patients accept it? Will our clinicians, hematologists, nurses, obstetricians accept this? And hence, the trial that we've embarked on is called TAPS-2 trial, transfusion antenatally for pregnant women with sickle cell disease. We know that for children, it reduces the risk of stroke. We know that for those having operations, it improves outcome. This may improve placental pathology and minimize some of the complications Laurie has alluded to. But will our patients accept it? The TAPS-2 trial is set to try and answer that. So this trial will assess the willingness of pregnant women with sickle cell disease to take part in such a study to address precisely whether exchange blood transfusion will improve outcome or not. The second study that we're embarking on is if a mother wants to know whether the baby has sickle or not. Currently, 2022, we put a needle into her tummy, take a sample of water from the around the baby or from the placenta to try and find out, can we not look at the mother's blood and actually identify the fetal DNA or the baby's DNA and avoid the risk of miscarriage associated with this? So far, we've done 64 of this, 57 we've got right, 7 we were unable to, the results was inconclusive. So clearly we've got funding to look at the further 100 to see whether this may prevent our mothers needing amniocentesis or chorionic villus sampling. I've given you our data on pre-implantation genetic diagnosis, which will answer precisely Ida's question of avoiding her baby having sickle cell disease. And finally, I feel that we may have a solution for sickle cell disease through women's health. And this is why your organization perhaps providing the advocacy to get funding into providing a cure for sickle cell disease may be so important. Wouldn't it be better if we identify a baby with sickle cell disease in the mother's womb? Most of our mothers are actually carriers of sickle cell disease. And in those mothers, they cohabitate with the baby for 9 months and tolerate each other immunologically for 9 months. Could the mother be a recipient, be a donor of stem cell transplant for the baby in utero to either provide the cure rather than offering termination to provide a cure in utero for the baby to then carry on with a good outcome post-delivery and continuation of the child's life afterwards? Or in fact, the mother and baby may become tolerant to each other such that we can use the mother's bone marrow to cure the baby. This is where I will stop. Thank you.
Thank you very much for this speech. I can see there are already comments in the chat, and I can see also some hand raised. So maybe we can go first to the floor and then we can address the questions in the chat. So I can see Dr. James, maybe.
Thank you very much, Eugene. As ever, very clear, very helpful. And I've just got one question and an observation. On the observation, I just want to say how supportive we are of more research, and particularly your last point about in utero work. So we welcome that and wish you well with that. The question I have is about the age. So in your presentation, you said that you're seeing in clinic people with sickle at an older level. The bar chart was helpful. And I'm trying to understand whether there's anything that is particular with age and sickle that is different to the general population? Because as I understand it, people are advised to have their children earlier rather than later, although more people are having children later. So what I'm trying to understand is, does the age issue just apply across the board, whether one has sickle, or are there any other raised risk factors with sickle and age? So that's my question, and thank you again for a great presentation.
Yeah, thank you, John, and thanks so much for your support. I think that clearly in most of the countries now, it's quite right that women patients are being seen almost yearly for the assessment of their sickle. Clearly, the general population, and my experiences in the UK, when I started as a consultant in 2004, only 4% of our mothers were over 40. Now it's 15%. So the general population is such that there are increasing age in terms of having a baby. For our patients with sickle, the question is that we know that in men, there is gonadal sickling, but none has been shown in women as such. And the data of using the anti-Müllerian hormone, which is a marker of ovarian reserve, we are showing that is you get a lower level much faster with age in sickle than non-sickle. So actually, if they leave pregnancy till say over 35, they may actually have issue with subfertility if they leave it later on. So the rationale is to say that they may have ovarian failure early, so don't leave pregnancy till too late.
Thank you very much.
And I think that also the manifestation in terms of organopathy may be higher with increasing age as well.
Okay, thank you very much. So from the chat, from your presentation, Dr. Oteng, you advised stoppage of hydroxyurea in a planned pregnancy. Can you say a word on those who may present when they are way into pregnancy and are on hydroxyurea? This is noticed even with initial discussion and education.
Yeah, so if I understand it correctly, if they're already on hydroxyurea or hydroxycarbamide and they come into pregnancy with it, our advice is for the pregnancy to continue, but to stop the hydroxycarbamide. During pregnancy, there is very little data, human data, showing that hydroxyurea is associated with teratogenicity. So we often will advise the pregnancy to continue, but there is significant animal data associated with teratogenicity in the use of hydroxycarbamide. So we don't advise the termination of pregnancy, we advise the pregnancy to continue, but to stop the hydroxycarbamide.
Thank you. I see Dr. Hevi. You want to say something?
Oh,
Hevi.
hi there. Sorry about that. I was just trying to connect my audio again. I tried to come yesterday, but I wasn't able to connect. So my name is Gervais. I am a sickle cell and stem cell transplant patient, but also a registered nurse working in hematology here in Canada. But I did have a question. Thank you very much, of course, Dr. Oteng, for your amazing presentation, very informative. But I was just wondering, you outlined some different complications and risks associated with pregnancy for sickle cell patients. I was wondering if you had any literature or experience on pregnancy with your sickle cell stem cell transplant patients? Anything along that line? Because there really isn't very much out there. And so I'm interested. I'm about 4 years post stem cell transplant now, and getting towards the age where I'm thinking of having a family of my own. I have frozen eggs and things like that already, so I would have to go the IVF route. But I was just curious about the potential risks or dangers and things like that associated. If you had any, I would be happy.
That's right. So I think in a way you actually, and congratulations for having gone through this and actually, success in terms of a cure. I will answer in specifics with regards to yourself. It's good that you've got frozen eggs, and hence in the future that could be used. We haven't had a lot of experience because, as you are aware, this is a very new field. We have actually managed to get a grant in terms of through King's College to start precisely doing this. But in the UK, it's been done at Hammersmith a lot. And so far, we haven't had the pregnancies coming through because in the UK, the transplant has been done in children, and we are only beginning to do it in adults. So I'm afraid I don't have any data, but in terms of generally using frozen eggs, in some centers, the success rates are coming through to about 20, 30%. But the advantage from your is that actually they could do it sequentially because they will have significant amount of frozen eggs available. Clearly, the other point where I feel that we have to look into the in utero stem cell is the reason why you needed to have frozen eggs is that in actually preparing you for the transplant, the medications do affect your ovaries. Mm-hmm. Where the donor is tolerant to the recipient, then you don't need those medications to prepare. So if the mother is a carrier and immunologically they tolerate each other for 9 months, then it may be that you may use the mother's bone marrow for the transplant without needing so much to affect the reproductive organ of the recipient. And this is where I think the in utero argument comes in, and we have to do more work such that the donor and the recipient tolerate each other, so you don't need to suppress the immune system of the recipient by so doing suppressing her ovaries as well.
Okay, sounds good. Thank you so much for your answer. I appreciate it. I know it's hard to be at the forefront of all of these new technologies because, I was one of the first here in Canada, and I know I'm going to be one of the first to go out and have kids. So I'm the scapegoat.
Hi, Rivi.
Marvelous. Congratulations. Yeah.
Thank you guys. Appreciate it.
Thank you.
If I can add some information, I'm in charge of sickle cell disease adults in Necker Hospital, and we perform bone marrow transplantation in adults in 6 years. So I can respond a little about this. We note one natural pregnancy in an adult treated by bone marrow transplantation, but with reduced intensity conditioning. I think the fertility after bone marrow transplantation most depends of the conditioning before the transplantation. So if you talk about this, your conditioning, I think I will be more precise for your. Do you know the type of conditioning if it's myeloablative?
Yeah, I think I got the non-myeloablative type. I had the Campath or the alemtuzumab, and then the 300 centigrade of radiation.
So for this kind of conditioning, I heard about 3 pregnancies in US, spontaneous pregnancy, but that's depend of the level of your ovarian reserve before the transplantation.
Okay.
That's data too.
Sounds good. Thank you guys very much. Appreciate it.
Okay, I would like to add something, because we don't forget that you are not a SCD patient anymore, but your eggs are carriers of the SC gene. So you have to study your partner before you get pregnant.
Of course.
It's important not to forget this. Okay, is there any more questions?
There was another question in the chat from Dr. Dora Bashir. It was hydroxycarbamide has been used in some cases with good outcome after second trimester when transfusion was not possible because of previous DHTR or bad outcomes of previous pregnancies, or if severe complication occurs, Thalassemia, etc., after second trimester. So it was more a comment than a question. Okay, just rechecking the chat. I think everything has been addressed from the chat. If I'm wrong, please correct me, because there are many comments. It's not always easier to follow.
Yes, there are a lot of comments. I don't know if the people that did the comments wants to say something.
I mean, I think the point about the hydroxycarbamide, clearly in pregnancy, we have to be extremely cautious using medications in pregnancy. And I think that whilst there has been some successful outcomes with hydroxycarbamide, the data is not there to use it in pregnancy. When I was a student, sodium valproate was being advocated for epilepsy, and we now know that is something that we must avoid. It takes a long time to see the outcome in the baby, and if there are alternatives, we should use the alternatives. And even in the context of blood transfusion, where in Jehovah's Witness or someone where it may not be safe, actually ensuring that you've got a multidisciplinary team to use immunosuppressant, you may still be able to consider and avoid medications that you are not sure the implication to the baby.
Thank you very much.
Speak. Yes, I agree with that. That hydroxycarbamide is contraindicated in during pregnancy. But when we have histories from patients, few just less than 10, but with low dose of hydroxyurea, when there are very many complications with vital prognosis engaged. And so I think it's, we use it. I remember a patient with a severe delayed hemolytic reaction and with no blood possible, blood transfusion possible. So when you have not other ways to progress in the pregnancy, and she has a premature baby with, I think it was born at 28 weeks pregnancy, and but life and she was very happy. So we told her that it was not possible to have another pregnancy. So she had one child and it was okay. But so I think it's really exceptional to use hydroxycarbamide, but when not other way is possible and severe complication occur, is the only solution.
Thank you.
Thank you very much to all of you. So one last comment I'm just reading. Thank you to everyone who spoke today. It was very informative for me, as I have not gone through pregnancy as yet having sickle. So I will say maybe we can address to all the panel of today one question that was addressed before to Ida, but Ida, you have the chance to give a second answer if you want. Was like, what would you suggest to a couple, so not only to the female part of the couple, but also to the other partner, male or female or whatever, what would you suggest to start the journey of having a baby? And well, no, I will just ask that for first, not too complicated. So I don't know who wants to talk first, but please take the floor. And
first, I guess I want to say that you have to, like I said in my presentation, to prevent and to check each other if you have sickle cell or whatever, who maybe the male is the one who has the sickle cell disease, then you have to check the female. So that's the first part. And second part is what I said, is you have to find yourself a really good doctor that wants to think along with you in the journey of your pregnancy, to make a protocol, like I said, protocol of delivery, and who is coming if you have a crisis whilst you are delivering. And actually, yeah, that's it. It's a really hard journey with a lot of pain if you have sickle cell and you are getting pregnant. But yeah, you know what you're doing it for. You're doing it for a lovely child, so the outcome is lovely, but it's hard. So that's it from my part.
thank you.
Ida, sorry, can I ask you, what do you think the patients' associations can do for help these people, or these patients, or these women?
Actually, maybe we can do a lot. Maybe we can come along to speak with doctors, or to have already what's the name again? Oh my god, I forget the name. To have oh wow, I forgot the name.
Maybe can I help?
Yeah, please.
So today spoke Laura Joseph, maybe? Do you remember?
Protocol. I wanted to say protocol.
Protocol? Okay.
Yeah, so if we have a protocol, maybe we can do with all the organization in whole Europe, so we can discuss the protocol, what is important, and what do we have to take care about, and then we can make just one protocol, and then every doctor can take it out of the wherever it is, and then you can make a personalized protocol for your patient. I don't know, it's just an idea, but you can do a lot of things actually if you think along.
Yeah. I mean, I agree completely with Ida. In 2004, when I arrived at my hospital, I thought this is precisely what we needed. And I thought, actually, let me write to our national college to see whether we can produce this at a national level. And a colleague said, why are you going to waste your time doing that? We spent about a year, 2 years to produce the guidelines. And almost every month we get a note from hospitals saying how important this is. And we've revised the guideline and published it last year. I think your advice that maybe we should ensure is European-wide becomes very, very important. We do not have all the answers, but it means that heads come together and provide recommendations based on what our patients are saying, what the literature is saying, and it actually gives us a consensus to move forward. So irrespective of which hospital you go to, there is a guideline that could be personalized to the individual patients. And I think we have to make that political point. When you go into research, often you are told that actually for sickle, there is not enough money for you to do the research that you need to do. So actually we have to politicize this and ensure that policymakers put money into innovations in the management of sickle cell disease and also in women's health and in pregnancy. And I think this is so important for patient advocacy group for us to work together to ensure that we have a common goal, both at the national and also international levels. So I really admire the work that you are doing, Ida, Cassandra, and the whole team. And I think that we should work together going forward.
Thank you. I think Brigitte Gristock, you have your hand on. You want to say something?
Sorry, yes. Although my question wasn't directly to do with the question that was just posed, so I could come back to it if you want to continue this discussion.
Okay. Miriam, you want to say something about this?
Hello, everyone. Not exactly about, well, it is just a generic comment about when this discussion should happen. I know that the session is about pregnancy, but considering that pregnancy should, as much as possible, be planned, I think that the discussion should happen way, way before an initial discussion when transitioning from teenage to adulthood, and when you are more, when you start getting sexually active. And we also have been discussing this from a very, I would say European, but it's Europe, the United States, Canada, but sexually active and the risk of pregnancy start in different ages, depending on the area of the world where you are, and access to healthcare is different as well. So that's why I say that this is a discussion which is really, really important, and it should include contraception as well. So talking to a sickle cell patient of what it is like, because ideally, the pregnancy should be planned, and everything that we have discussed is really, really important. But it is also important to bear in mind that it should be planned, but accidents do happen. And a lot of people don't know what it's like, have no idea what it's like, and increase their risks due to that, and don't have access to primary healthcare. So it's just about, we have been focusing very much on discussing with the pregnant women, with the couples, but it starts with the patient, male or female, way before, and then the conversation needs to be more focused on the actually planning when the pregnancy is approaching. I didn't have any children, but at the time, the possibilities were much more reduced, but I did discuss it, I did investigate, and I ended up by making my own decision. But I think that it is very important, and for the patient associations as well, to have this discussion in different stages and discuss which are the possibilities, which are the risks, that it is possible, but you should think about it. That's it. Thank you.
Thank you, Miriam.
Thank you very much. So maybe, Brigitte, do you want to comment on?
Thank you. Yes, I'm a doctor. I'm not a sickle patient. I'm a sickle doctor. And somebody has just rung my doorbell. I might have to go. I'm really sorry. I will come back to you if I can.
Okay, sure, for sure. So maybe following our panel, I don't know if Dr. Joseph wants to add something. Cassandra is no more with us, as I said before. She apologized.
I just had that when I see many patients until 18 years old, and during the first consultation, I try to talk with them about transmission of sickle cell disease and necessity of planned pregnancy and to search carrier. I try to discuss about this in all my consultations, the first one, because I think it's very important. And I'm totally agree with other speakers who say that.
Thank you. So, yeah, please.
Yeah, I think in terms of Marian's point, actually it is extremely important. And first of all, Mariam, you alluded to perhaps being European, Canadian, US centric, but clearly it is a global disease. And I think what we all have to advocate for is the importance of universal newborn screening worldwide, because that will save lives. Secondly, you are right, we should take a life course approach, and those with the disease are often seen almost yearly, and the opportunity to talk about family planning, and also partner becomes very, very important. And I think that actually the lens that we should be looking into is taking a life course approach to the management of sickle cell disease. Thank you.
Thank you. So, Brigitte, you wrote your back.
Yes, I'm really sorry about that. I'm a doctor who looks after patients with sickle cell. I don't have sickle cell myself. I had a comment about breastfeeding because somebody made a comment about how it's important to encourage breastfeeding. I've got 2 children of my own. I breastfed them for 3 years altogether. I'm all for breastfeeding. I'm completely for it. But I also have patients who are on drugs that you're not supposed to give when you're breastfeeding. And I've had some patients who were so keen to breastfeed because of all the good things about it that they wouldn't go back on the medicine, and they kept coming into hospital because they were unwell. And I was wondering how that was approached by some of the other clinicians and how other patients had that approached with them, because my personal feeling is that although breastfeeding is excellent, if mum is really ill, that's probably worse for the baby than having the baby fed by some other means. Everyone has to make their own decision. I do understand that, but I did have some patients who'd been told that breastfeeding was so good that there was nothing, nothing should stand in its way. And I did wonder how that had been presented to other people.
Yeah, I mean, if I could take that on, first of all, it's important for our services to ensure that we do a lot possible to keep mother and baby together, and hence the importance of having, say, a high dependence unit on the maternity unit may ensure mother and baby stays together. Occasionally, yes, mother may have to go to critical care, but it's important for us to design our services that way. Secondly, actually, for our patients with sickle cell disease during pregnancy, I can't think of any medication in almost 99% of them where breastfeeding may be contraindicated. Occasionally, we alluded to perhaps those where transfusion may not be needed, like the use of eculizumab and other medications that may be important to provide immunosuppression and methylprednisolone, etc. In those scenarios, some of these medications, very little cross into breast milk. So I think for sickle, by and large, most of the medications, breastfeeding is not contraindicated. I do accept that sometimes for some pregnancies, some deliveries, irrespective of sickle, breastfeeding just is not working. And hence, in that scenario, they may have to ensure that they go timely onto bottle feeding, and it shouldn't be a dictum that breastfeeding is a must. And also clearly the couple, the mother should have the choice, and some mothers, irrespective, may choose not to breastfeed, but ordinarily the evidence do support breastfeeding.
Thank you for that. I guess I'm thinking of those occasions where patients who are unwell are not able to breastfeed, or at least that the drugs they are given are said to be contraindicated for breastfeeding. I mean, I think that the literature still says you shouldn't breastfeed on hydroxycarbamide. I think there is some disagreement about whether that's necessary or not, but I've certainly had patients who've read that they read that on the internet and have decided not to take their hydroxycarbamide because they want to breastfeed, and have then ended up in hospital quite unwell as a result. So it was just, I guess it was just a comment about that. And I don't know what's happened, what patients have been told as well. I mean, what did they do? But maybe maybe there's no patient on the call who's been in that specific situation anyway. I don't know.
Thank you. I think we are going to close. It's a very interesting debate. Everyone wants to do a last comment to summarize all of this, if it was possible, or a taking home message. Hema, do you want to say something just to finish?
No, actually, there are a lot of useful things that have been said. So, yeah.
Okay. Dr. Eugene?
What I will say that it's good that we are coming together internationally on this. Clearly, it's a global condition, and we should play a strong advocacy role for developing countries as well. But with all the work that we are all doing, I think that we should be hopeful that most patients with sickle cell disease should reach an age where they are choosing to have a baby, and they will have a good outcome for mother and baby.
Yes. Dr. Laura? Joseph Laura?
No, I have nothing to add.
Okay, thank you. So, Mary Angela, do you want to close the session?
My pleasure. It has been very important, the session today. I must say that I'm very happy to have seen such a nice debate among health professionals and patients and caregivers. I think this is one of the main objectives why we are here today at ASCAT Congress. This was really one of the bases of starting such a project, of having a patient therapeutical session at ASCAT, was really to strengthen the dialogue among health physicians and patients, because we know this is one of the right pathway to follow for giving a better quality of life, but also to increase the knowledge of research. So it's a win-to-win approach, and we are glad to have seen one demonstration of it today, talking about pregnancy. So I just would like to express all my gratitude to the speakers, to the moderators and to the participants for the great outcome reached today. And just would like to say that tomorrow we are going to talk about more bone marrow transplant. And then there will be the outcomes of all the 4 sessions we had at the plenary of the plenary session, at the final closing plenary session of the ASCAT. So I hope to see all of you again and have a nice evening or afternoon, morning, according to your jet lag. So thank you very much and have a nice day. Bye-bye.
Bye. Thank you.
Bye.
Thank you
very
all
much.
very much.